We're thrilled to have you join us for today's webinar on navigating hospital stays. This learning event is a part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to our website for on-demand viewing at a later date. Everyone registered for today's session, whether you attend or not, will be receiving this recording in your inbox. Please know that all phone lines have been muted, but you can still ask questions. We will have a Q&A session at the end of each presentation. Please feel free to enter your questions as you think of them into the chat box, and we will be sure to keep track of those for the Q&A session. I want to give a special thanks to our webinar supporter, Amgen. And for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with neuromuscular disease. Our community education and recreation programs are designed to connect families and individuals. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free, and you can see the link in the chat for more information. Now it is a pleasure to introduce our first speaker right here from our MDA family, Joel Kartner. Joel is a lawyer and public policy professional working as the Muscular Dystrophy Association's Director of Access Policy. He leads MDA's efforts in conceiving, enacting, and supporting the implementation of public policy proposals that expand access to care for the neuromuscular disease community. Joel has a background in health, disability, and education law, including complex litigation and policy. He received his JD from Quinnipiac University of Law and his BA in Political Science from the University of North Carolina, Wilmington. Joel, thank you so much for being here today, and I will pass the time over to you.
Happy to be here. Thanks so much. We just wanted to give you all some quick kind of tips and tricks for navigating hospital stays. The first and maybe broadest of them is kind of tips for self-advocacy when in a hospital setting. And the biggest thing to remember there is, as we all know, when you're in the hospital, either for yourself or for a loved one, it's among the worst days of your life, right? But the biggest thing to remember around self-advocacy in the hospital is try to stay calm and try to remember that for as stressed as you are, the healthcare providers that are around you do genuinely want to help you or your loved one. So you are all on the same team, and you all are rowing in the same direction in most circumstances. And there are a ton of resources that you can leverage for yourself as you're doing your self-advocacy in a hospital. First of all, most hospitals that I've ever run across, and I've run across a bunch of them at this point, will have on their website a patient's bill of rights, which is basically just a hospital laying out its commitment to um, access to care and humanity for all of their patients. So just having that handy when you do need to advocate for yourself, regardless of whatever reason, can be super helpful just in terms of reminding these folks that, like, hey, your institution has made a commitment to upholding these values that you've laid out. Um, but other than just the Bill of Rights, there are various tools that you can use to help you self advocate. So, remembering that there are resources like hospital ethics boards, patient advocates, there often is a member of staff that's something like the head of patient experience, or kind of some title that's similar to that, whose job it is to make sure that you are having as pleasant and as respectful a hospital stay as possible. There's also other facility staff that might be able to help you. And then in the worst case scenario, of course, there are always lawyers to help you navigate processes when you need to. Um, so just as a general matter, when you're doing self-advocacy, just remembering that you have tools at your disposal to navigate these um, waters as easily as possible. In terms of requesting a transfer, there is, generally speaking, a right to request a transfer as part of the general principle of patient autonomy that's in law federally. Basically, US law is set up to the general principle that patients and those that love and care for them have a right to be able to receive healthcare in whatever environment they feel most comfortable in. And if that means, facilitating a transfer of either physicians within a hospital or transferring between hospitals, that people should be allowed to do so. There's also a right to request a transfer under the Emergency Medical Treatment and Labor Act, or EMTALA, which basically the thrust of that, and there are complexities here, but the thrust of transferring under EMTALA is, if you are stable, then you have the right to transfer out of an emergency facility into a more generalized population or another facility. And if you are not stable and are in need of emergency care, there is a right to transfer you to a facility that can provide you emergency care. The major limit on both EMTALA and this general principle of patient autonomy is um, the hospital that you are seeking to transfer to needs to be able to treat you. And this can be particularly tricky in terms of the neuromuscular disease community because, as all of you are aware, many conditions, actually all of our conditions, are rare in nature. And so there are often limits on the providers that can effectively treat members of our community. So the biggest kind of barrier to transfer may be ability to treat you effectively at the facility or by the provider that you wish to transfer to. There are also, particularly in emergency circumstances, there are capacity issues. So just, does the emergency department that you're trying to transfer into have enough beds such that you can transfer there safely? Things like that. Insurance can also prove to be, I'm sorry, there was a very loud car just going by my window, so I'm going to start that over. Insurance can also be a barrier to transferring either provider or between facilities. They may deny your claim when you request a transfer. Um, it's important to remember that you always have the right to appeal an insurance decision. And there again, the healthcare provider that you are both trying to see and trying to transfer from, they are your best advocates there. So working with them to move you through the transfer process is going to be incredibly important. In terms of kind of smaller things you can do to request a transfer, you can always request a meeting with the hospital's ethics board, speak with the chief medical officer, or appeal to the hospital or medical system's patient advocate, again, to make sure that you are kind of using the levers of power within a hospital to facilitate your transfer as best as possible. And then in terms of insurance, publicly, so Medicaid and Medicare, there's often an enrollment process for treating physicians, particularly when you need to travel across state lines. So again, with the neuromuscular disease community specifically, it's often the case that to see that hyper specialized provider, you may need to transfer across state lines, and when that is the case, that enrollment process can take some time. So just kind of being patient or knowing ahead of time that that is something you need to navigate through can be super helpful as well. Requesting a second opinion is another instance where you might want to request a transfer or might need some help. And particularly with requesting a second opinion, really you should always feel comfortable requesting a second opinion. I know it can be kind of uncomfortable because you are, asking a healthcare provider to formally second guess in some instances their opinions. But the thing about requesting a second opinion, particularly, is healthcare providers are almost always very, very open and very, very like they want to help you facilitate that second opinion because they want to be sure that you are as comfortable and as firm in a diagnosis as possible. Most hospital systems that I know, when you request a second opinion, they will give you a list of physicians to go get that second opinion from. It varies hospital to hospital, the number of second opinions or people that can offer that opinion that they're required to give, but a lot of them are required to give a set number. Um, they also often have internal policies and documents that guide kind of how requesting second opinions work. So always be comfortable along with requesting that list of providers, but feel free to pull on the lever again of internal documents and policies um, to request that second opinion. And then changing providers generally, obviously that can be super stressful just in terms of the sheer volume of medical record that we often have as rare disease patients to move from provider to provider, or even if you, for example, need to change primary care providers and need to get them up to speed on what your kind of baselines are. The good news with that is, given the rise of electronic medical records or EMRs, that transfer has gotten sorry has gotten somewhat easier as the technology has evolved. Many healthcare providers and systems will have portals that can facilitate the transfer of medical records from physician to physician, so that can be super helpful. And again, leaning on patient advocates, either at the facility that you're transferring from or healthcare provider that you're transferring from, or who may be retiring, for example, or leaning on the patient advocate at your primary care physician or wherever it is that you're transferring to, can again be super helpful and just kind of trying to make sure that that transfer of information can go as smoothly as possible. So I know I just threw a lot of information at you in a very short amount of time, but with that, I will stop there and open up to Q&A.
Thanks so much, Joel, and thank you for guest speaking today because I know that you came in last minute, so we really appreciate the help that you offered us. And I don't see any questions in the chat, but I was reviewing some questions that were submitted upon registration. So I do have a couple, and if you can answer them, feel free. And if not, we can maybe ask our next presenter. So the first question I have is, can a patient check themselves in and out of the hospital?
So a patient can always check themselves into a hospital. In terms of inpatient, that may be a little bit trickier, especially if you're moving through the emergency department. You may need to go through, emergency settings first and then get their approval to do an inpatient stay, things like that. In terms of checking yourself out of the hospital, the thing that you may run into there is checking yourself out against medical advice. That's not always a bad thing. You may feel more comfortable with your health setting than your provider might. But in the instance of checking yourself out against medical advice, that may present issues with insurance on the back end in terms of their willingness or ability to pay for certain procedures. It can very much vary on a case by case basis. But generally speaking, you are always free to check yourself out as needed.
Great, that's a good point. Thank you. And then another one, you brought up working with a patient advocate. If you know that your MDA clinic or your primary care physician has a patient advocate on staff and you're in a hospital visit, can you still work with the patient advocate from your regular doctor's office, or do you have to only work with the one from the hospital?
So that's again kind of going to be a very hospital specific question. But what I would say there is it's always worth the ask of saying, hey, here's this person that I'm very comfortable with. Do you mind if we loop them in? And if for whatever reason there are issues with that, kind of cross that bridge when you come. But my biggest piece of advice there would be there's never harm in asking that question.
Great. Well, I don't see any other questions in the chat. So thank you so much again, Joel, for coming on last minute to share your knowledge with us.
Of course, happy to help.
Thank you. All right, now it's my pleasure to introduce our second speaker today, Julianne Meiser. Julianne is a licensed clinical social worker with the Children's Hospital of Philadelphia. She earned her BSW from Eastern University and her master's in social service from Bryn Mawr College. Julianne has supported families throughout the medical system for over 10 years in both inpatient and outpatient settings. Currently, she is the social worker with the neuromuscular team at the Children's Hospital of Philadelphia. She is passionate about serving the disabled community and connecting patients and families with services. Julianne lives with her husband and 5-month-old son in Bristol, Pennsylvania. Thank you so much, Julianne, for being here, and I will turn the time over to you.
Thank you so much, Sarah. He is 6 months now, so time's moving on. So like I said, like Sarah said, my name is Julianne. I'm a social worker at the Children's Hospital of Philadelphia, also known as CHOP. We see a vast majority of all neuromuscular diseases, DMD, SMA, limb-girdle, ataxia, really, you name it. I've met somebody, we've addressed it. I've been working with this team since 2023. And I have a real passion for the neuromuscular community and the unique challenges that these diseases present. I am going to share my screen for you all. Okay. Here. Can we see it okay?
Yes.
Yes, good. Okay. So today I want to talk to you about hospital stays. Being inpatient in the hospital is something that can feel really isolating and honestly traumatic when you don't really know what to expect. Prior to working with the neuromuscular team at CHOP, I actually did work in the inpatient setting for many years. And my hope today is to give you some clarity on what to expect in the hospital system. And my intention really is to demystify the hospital setting and to help you feel just a little bit more in control of your stay. So to start off, we're going to talk about the difference between a planned and unplanned admission. Then we're going to talk about what to expect, like who to expect to meet during your hospital stay, really like just the different members of your care team. Lastly, I want to go over some details related to just some medical records and billing. At the end of the presentation, there will be an opportunity for Q&A, just like we just had, so we can talk about any questions you have at that time together. So let's begin by talking about the two major types of stays. There's planned and unplanned admissions. The difference is somewhat obvious, but just to explain, planned admissions are scheduled and expected. These could probably be something like a planned procedure, like maybe orthopedic surgery for scoliosis. You and your doctor are able to talk ahead of time about the reasons for the stay, and this allows you and your family to have a chance to prepare. Discharge dates can still be uncertain, even with planned visits, but your doctor can give you some sort of an idea of how long you expect to be there. Unplanned visits, however, are generally an emergency. Maybe something happened at home or school or work that made it really important that you head to the hospital right away. There is significantly less time to plan for these visits, and it can really be a scramble to get yourself out the door and to the right place. And really, there's no way to know how long you'll be there either. Let's talk about these unplanned visits first. Respiratory problems are one of the top reasons that people with neuromuscular diseases go to the emergency department. These can be really sudden events and can be very scary. It's really difficult to think clearly in this scenario. One of the best things that you can do for yourself to prepare is to create and follow an emergency plan. To make an emergency plan for going to the hospital, you need to think through the information that you want to share with your hospital team, your preferences for where you go to the hospital, and any items that you might want to bring along with you. And you'd want to try to write this down or somehow communicate this to a loved one ahead of time. Your emergency plan should also include a medical summary. Your medical summary should include your diagnosis, medications, past surgeries, and information on any daily support that you require, like nighttime respiratory support. The MDA has a really great resource for this in the MDA emergency room summary. I've put a little piece of the first page right here. I recommend filling something like this or something like this out and having it in a place that you can access quickly. In the event of an emergency, you might not have time to bring anything to the hospital except for yourself, which really is the most important thing. But if you did think about it ahead of time, I do think having something like a go bag is helpful to have on hand. This can be like a duffel bag or some sort of small bag that you keep close to your front door in a spot that's easy for you or a family member to access. It should contain the medical summary we talked about earlier, as well as some important documents and other things like a change of clothes, maybe your advanced directives, a copy of your insurance cards. Additional care items like a phone charger are also really helpful to have on hand. These items should be things that you're not going to miss in your day-to-day life, but will make things simpler if you have to head out the door pretty quickly. Caregivers, you also try to remember that you might need some things before you head out the door as well. However, sometimes you really need to get moving quickly and it's not possible to remember everything. So know that you can always have someone bring the things that you need to the hospital afterwards. One of the most challenging parts of an unplanned admission is advocating for your care and explaining your diagnosis to the hospital staff. Neuromuscular diseases are rare, and many hospitals and emergency room doctors are not going to be experts in your condition. In the event of an emergency, you might also be in no place to explain your condition yourself, which is why it's really helpful to have a written summary or a medical alert bracelet, or even just bringing a friend or an advocate with you to the hospital. An advocate can be a parent, a spouse, a friend who is familiar with your condition and can speak on your behalf if in the event that you're in a place where you can't speak for yourself. Your advocate can be someone that you have officially designated to help you with this decision making, like a power of attorney, or another loved one who is just there to help speak up for you and make sure that things are going well. A power of attorney is a legal document that allows another person to act on your behalf. This is something that you would have had to prepare ahead of time before coming to the hospital, and usually with the help of a lawyer. One important note is to ensure that you're well aware of any disease-specific protocols that may need to be communicated to your care team. An example of this is PJ's protocol for Duchenne muscular dystrophy. It's named after Philip James, PJ, Nikoloff, who was a young man who died from complications related to not receiving appropriate stress doses of steroids during a hospitalization for bone fractures. PJ's protocol was established to give guidance to hospital staff on the use of steroid medications for individuals with DMD. You should ask your neuromuscular care team that if there are any disease-specific protocols for your specific diagnosis, DMD or otherwise, that you would need to communicate to your care team in the event of an emergency. And I would suggest adding that to the medical summary. Unfortunately, in an emergency, you cannot always choose the exact circumstances that you will go to the hospital with, but I hope with these tips in mind, it makes the experience just a little bit smoother for you. Planned admissions are a little bit different. They allow you to prepare for your stay ahead of time. You and your doctor can talk about the plan and why intervention is necessary. I encourage you to ask questions and discuss the specifics of your stay with your doctor prior to setting your admission date. Similar to unplanned admissions, make sure you bring all of your important documents. I would also consider any personal care items you might want to bring, or really anything that you find comforting that's appropriate for the hospital setting. You should also take the time to plan your transportation for drop off and discharge. Family or friends may be able to help you, or you can always contact a non-emergency medical transportation company. Also consider other household logistics that just might need to get arranged, like any child care needs or any care needs for pets, mail delivery. If you use a home health agency, letting them know about the dates of your admission are really helpful. Managing your expectations and preparing mentally for your stay really is just as important as making sure you have the proper documentation. Hospitalizations can be really upsetting. And there are some things that you can do to make things a little bit easier for yourself. I recommend doing your best to understand the purpose of your stay prior to the admission, because I think this helps you with just understanding why you're here, how long you need to be here. You should also familiarize yourself with the hospital Bill of Rights, which is a list of rights that you have as a patient that can include ways that you can advocate for your care needs. On the slide, I have a copy of I have a little piece of the first page from the Bill of Rights at the Children's Hospital of Philadelphia. I also think that managing expectations for the hospital environment is really helpful. Hospitals, like any institution, can be really uncomfortable. You should prepare yourself to be in an unfamiliar environment where you might not be able to control the temperature of your room, and the beds are probably going to feel like they're made out of cardboard. No matter what, your stay is going to be a change in routine, which can be really uncomfortable, especially if you are not expecting it. I suggest preparing ahead of time or talking about your fears with a trusted friend or a professional counselor. Meditation and other relaxation techniques are also really great tools while you're in patient. Here are just some general hospital policies that you are probably going to want to look into prior to coming to the hospital if you can, or to find out once you get there. These will vary depending on hospital to hospital, but there usually are set visitation hours for the hospital and often a limit to the number of visitors who are allowed at a time. There are also sometimes restrictions on the age of visitors and restrictions on like pets visiting. At the adult hospital that I worked at, there all visitors needed to be 16 years or older, and animals were not permitted. And we had specific visiting hours from I think 11 a.m. to 7 p.m. daily. Hospitals will also have different views on outside food and beverage. Usually it's okay to bring with, but you do want to make sure that if you're the visitor, that your loved one doesn't have any dietary restrictions that keep them from being able to eat what you've brought. Usually meals are provided for the person who is inpatient, but family members usually have to either go to the cafeteria or find outside food. And then there's just usually some prohibited items like weapons, legal drugs, alcohol, sort of thing. At the last minute, before you go to the hospital, I do think it's important if you have time and this is realistic for you to think about a couple of these things, like taking a shower right before you go. Before I had my son, my water broke, and I said, I'm taking a shower right now because I didn't know when the next time was that I'd be able to have a hot shower. And you might not be able to bathe again for a long time, really. Remove any jewelry or any valuable items that you don't want to go missing, and just leave those safely at home. You might want to also just, again, check to make sure that you have all your paperwork in order before you head out the door. One of the best ways that you can prepare is to have a support system, really just a network of people that you can call on when things get tough. You can designate someone to come with you to the hospital to provide support. I said this before, but this could be like a power of attorney, like somebody that's been officially designated by you, but it could also just be somebody less formal who you'd like to come along for extra support. I think asking friends and family to call if they can't come in person, or if someone's able to come and visit you, can really brighten your day. or even just having someone send a card to the hospital room or flowers. It really just brightens up the room and can make you feel a lot better. Now that we've talked about everything that you're supposed to bring to the hospital, let's talk about who's already there. So MDA has put together a really lovely cheat sheet for all of you to refer to after this presentation that fully articulates a lot of the roles of different members of your hospital care team. I'm going to be going through a few of them pretty quickly, so don't feel like you have to remember everything I'm saying right now. Honestly, I could probably give an hour-long presentation on just one of these roles, and I'm definitely going to miss aspects of what each of these do, but I hope that this is at least a little helpful summary. So let's start with the attending physicians. Attending physicians are your doctors. This is the person reviewing all the notes from all the different specialties that have come and visited you. They're making the decisions about what medications and treatments that you should be on. Attending physicians tend to be responsible. It depends on the hospital, but between 10 to 20 patients, maybe more, depending on the hospital staffing ratio. This also does change depending on the level of care you're receiving. Like I see doctors in the intensive care unit have less patients that they're responsible for than doctors in a med surg floor. If it's a teaching hospital, each attending physician will also have a team of residents. Those are doctors in training, people who have finished their medical school education and are now kind of interning under the doctor. It's usually about 2 to 5 residents, depending on the doctor. Residents are also reviewing your chart, also coming to see you. It's a little confusing because they will also say that, because they are the doctor as well, but you might get visited by a few different people, but know that they do have an attending who is also reviewing everything that they're doing as well. I recommend really getting to know your residents. I think they usually have more time to chat with you and answer questions, and really are there to learn. So they might be just as interested in you are as for what's going on. Specialists, especially doctors, are doctors who decide to focus on a certain part of the body or procedures. For example, a cardiologist is a doctor who will study the heart. In the hospital, these specialists are usually seen more on like a consultative basis. So you might only see them once during your stay, or maybe you see them every single day. Kind of depends on what's going on or why you're here at the hospital. I have a lovely picture here of our our doctor team from Grey's Anatomy. They are specialists. They are surgeons. So different kinds of surgeons, but that is a specialty. I can go through this briefly, but neurologists are the doctors who study the brain, but also for neuromuscle. Cardiology is heart. Endocrine doctors will do like your hormonal system, metabolic system. Pulmonologists are the lung doctors. Rehab medicine doctors are the doctors who oversee if you're like being seen by physical therapy. And honestly, there's tons. We could do this all day. I could list different kinds. Nursing, really the backbone here of the medical system. There are so many different kinds of nurses, but in general, nurses are the ones who follow through with the doctor's order for medication and treatment. Nurses have different levels of education depending on their title. So patient techs or certified nursing assistants, they assist with your personal care. So they help with bathing, dressing, helping moving you around the hospital room. Their goal is really to maintain your comfort and dignity while they're continuing to report to the other members of the nursing team. Licensed practical nurses provide basic nursing care under the supervision of RNs and doctors. They are licensed after completing a 1-year program and passing the state exam. Registered nurses deliver direct care to patients. They manage your medications and they coordinate treatments. RNs are licensed professionals with an associate's or a bachelor's degree in nursing. And then nurse practitioners are advanced nurses. So they either have a master's degree or a doctoral degree, and they can diagnose, treat, and prescribe medication. Many Many nurse practitioners specialize in specific areas, like neurology. We have a nurse practitioner in my neuromuscular clinic. In the hospital, when we talk about therapists, we don't actually mean the ones that you talk to about your feelings. We mean rehabilitation specialists that help you with exercises to get you functioning more like you were at home. So physical therapists help you with ambulation and transfers. Occupational therapists help you with practicing activities of daily living, like getting dressed, cooking, toileting. Respiratory therapists help work out your lungs and help you to build your lung capacity. And speech therapists help you with speaking and swallowing. Again, I could talk, they do way more than these things, but these are just in general what they do. Therapists also see you as ordered in the hospital. So sometimes you might see them every single day, or you might only see them once. It just depends on why you're there. I called this slide patient services, but some of these professions honestly could be categorized just totally unto themselves. So I just grouped them together for ease today. But just to start, a discharge planner or case manager is usually a registered nurse, or it's a social worker who helps to come up with a plan to get you home. Sometimes they order durable medical equipment like oxygen or a shower chair. Sometimes the care team recommends that you go to an inpatient rehab to get PTOC, OT services, and the discharge planner would help you to set you up with this before you go home. A social worker, me, can do a lot of different things inpatient, but generally is a resource for emotional support and community resources. The social workers at CHOP here, they help with different charity applications, and they can help lead family meetings and just help with communication in general. When I worked in adult care at the adult care hospital, I functioned a lot more just like a discharge planner. Chaplains are spiritual advisors who can come pray with you and your family, and they're also a resource for emotional support. Child life therapists are specific to pediatric care. They provide tools and ease the emotional burden for children in the hospital setting. Their closest equivalent for adult care is a recreation therapist. Recreation therapists usually provide activities in the hospital setting and an adult setting. A dietitian, it's very different than everybody else here, but a dietitian also is really, really important. And they manage a patient's diet and provide recommendations to the patient and the doctor with regards to nutrition. And lastly, a patient advocate is someone that you can call if things are not going well in the hospital. They can usually come up and speak to you directly in your room, or you can talk to them over the phone. Every hospital system has they call it different things. Patient advocacy is what I've seen most commonly, but they can help you to have your concern addressed. They can help with communication with the medical team and have a more easier line to administration and let them know that something's wrong. I wanted to briefly point out that there is always a chain of command in the hospital setting. This is an example using the structure of a nursing department. So I wanted to make sure that you know that there is always another staff member that you can elevate your concerns to for more support. So just for nursing, we'd start with the patient tech. That's the person who would help you with movement in and out of bed. Your bedside nurse is the person that when you hit the call bell and ask for medication, they bring that into you. If that person isn't able to handle your concern, they can bring it up to their charge nurse, which is usually also an RN who is kind of in a managerial position that day. And they are either overseeing all the nurses on the floor or just a few chunked out. The nurse manager usually is responsible for the entire floor. And then after that, we could go to the administrators, to the director of nursing, and then eventually to whatever the administration looks up beyond them. It's usually different hospital to hospital. We're going to discuss next. Well, we're going to move on to medical records and billing. To request your medical records, you need to contact the Health Information Management Department at your hospital, also called HIM. This department organizes and maintains your medical records. The HIM department can help you get your own medical records if you request them. You will probably need to complete a release of information if you are trying to get them to send your medical records directly to a third party, maybe for Social Security or something like that. Depending on the staffing available in this department, it might just take a few hours to complete your request, or it could take a few weeks. It depends on a couple different factors. Nowadays, most hospitals do also have an electronic portal. The most common one in my area is called MyChart through Epic. It allows you to have instant access to your medical records. So if you need just like 1 or 2 specific notes from your doctor, you can probably pull this yourself from the portal or send a message to your doctor's office and request them to like download it and send it directly to you. Billing, everyone's favorite, right? Here are just some basics for billing. Every plan really is different for how much they cover and what your responsibility will be. In your handout, we have some additional definitions for the terminology used for medical billing. So again, don't memorize what I'm saying, but I'm just going to go through a few quickly. A copay or copayment is a fixed amount that you pay out of pocket for a covered health service like a doctor's visit. So just as an example, when I go to the doctor, I have a $35 copay anytime I go, and that doesn't matter what we talk about, what we're seeing there, but ahead of time, you do have to pay that. Co-insurance is the cost-sharing arrangement where you and your insurance company share the cost of a covered medical expense after you've met your deductible. So you pay a certain percentage of the bill, basically. So if you might have like a 15% co-insurance, but your insurance will cover the other 85%. The deductible, which I just mentioned, that's the amount of money that the policyholder, you, has to pay out of pocket before the insurance coverage begins with that 85%. So that all depends. I've seen deductibles as low as $500 and as high as like $15,000, $20,000. So that just depends on what's available to you. An insurance denial occurs when an insurance company refuses to pay for a medical service or treatment, whether it's a claim for services that you've already received or for something that like they were like checking ahead of time to see if they could get it covered. This means that the insurance company is not going to cover the costs associated with this specific medical care or treatment. And the patient will be responsible for that care. You do have the right to an appeal. And an appeal for a denial in the insurance world is a formal request to reconsider the decision made by the insurance company. Usually when they deny coverage, essentially it's a way to ask the insurance company to review their original decision and see if they can come up with a different answer. Usually when they provide you with that denial, there will be information for how to file that appeal. Unfortunately, the staff providing care at the hospital are not going to know the details about your hospital bill. You're going to need to wait for your insurance company to process the claim, and you're going to need to wait for the hospital system to receive their reimbursement, and then they'll provide you with the notice, which could take, again, just a couple of days for them to reach out to you, or it could be few months or more. When you receive your hospital bill, you can look through it to see if you want to dispute any charges. Asking for an itemized bill is really helpful because you can go through these charges line by line to see if any of them just aren't correct. After that, you can bring your concerns up with the billing staff. There's almost always a phone number to call for billing questions. They like to make it very small and hard to find, but it is there. You can talk to the hospital billing staff and either ask them to explain the charge if it is correct and you just misunderstood, or if it is incorrect, they can remove that charge for you. The No Surprises Act, passed in 2022, aims to clarify patient responsibilities and minimize some of these unexpected costs. If you do receive a bill that you're not able to pay, there are some resources that you can look into within the hospital system. Most hospital systems have something called financial assistance, which is a program run privately by the hospital that can help decrease the charges for families with low income. You will need to apply for this program to see if you qualify. There's also a resource known as Emergency Medicaid. All hospitals must provide assistance to people who come into the emergency room, regardless of their ability to pay. Emergency Medicaid is often used in these scenarios to temporarily give coverage to a person who does not have medical insurance. This is temporary and really only meant to stabilize the person. Lastly, you can always tap into the resources of a patient advocate or a social worker if you feel that the billing staff is just not listening to you. You can talk to the patient advocate. They can try to reach out and try to see if they can help to get things settled. But if the bill is correct and you've tapped into every other resource and you're not really sure where to turn, but it's not something you're able to manage, you can try to reach out to a social worker within your hospital setting to see if there are any charities or grants that they know about that can help you with the hospital bill. And that is the end of my presentation. Thank you all so much for listening to my presentation. I've just been so excited to talk with you all today. Hospitals are really just quite a large topic, so I hope that this has helped in some ways to clarify some questions you might have, and I really look forward to seeing what questions came up.
Yes, thank you so much, Julianne. I feel like that was just full of helpful information. We do have some questions that were submitted ahead of time upon registration, and I also got a couple of questions from the chat. So we'll just jump right into it. Is it all right to have a patient's group home attendant be present to help patient with mobility?
Yeah, when I worked inpatient, I actually loved it when the group home staff would come because they are going to know that person better than anybody else. They usually would stay bedside. Sometimes I think the nurses love it too because then they have an extra set of hands to help. So in my experience, yes, that will depend on the hospital, but I think it's okay.
Now, I know, just wondering from your experience, have you ever had an issue with group home staff not being able to provide services in the hospital because of billing, maybe with Medicaid?
I have not seen they weren't able to like give medications or something like that. Like that had to all be done through the nurses. But as far as physically assisting the patient or being, you know, a friendly face who's coming by, no, there wasn't an issue as far as I know.
That's great. Okay, whenever I'm admitted to the hospital, the issue of intubation comes up. I don't want intubation, but they interpret that as DNR.
Yeah, that's really tough because there is something, you know, a DNI is a specific I don't know if I'm using the right word, like you can say you want to be a DNI, do not intubate, but you still want resuscitation. It's again, I think bringing an advocate for or having that written out very clearly is very helpful. Having those advanced directives with you so that the hospital staff can directly interpret it. DNR is definitely more common, which is probably why you're seeing that. But it is every hospital I've worked at, we can absolutely have someone be a DNI and not a DNR.
Good point. Thank you. This next question kind of goes back to the other one about having an aide available when nurses aren't available. This person says, are there aides that can be provided to help you when nurses aren't available? So if you don't have group home staff there to assist you, is there anyone the hospital can provide?
So the hospital does have like patient care techs while you're inpatient, like somebody as a certified nursing assistant who can help you with your physical tasks. There isn't necessarily somebody that the hospital could send home, like who works for the hospital, but there are home care options usually available depending on your insurance. Usually with Medicare, you can get, you know, for short term, you can have like a nurse come out and visit you at home, but you can also get a CNA that way too.
Great, thanks. Is it best to bring your own equipment to be used at the hospital, or is it best to use what they provide?
It depends on your situation. We do have families who prefer to bring their home equipment. I would talk to the hospital staff before you bring it. and let them know and see if there's any sort of like, let them determine if there's any reason why you need to be using the hospital grade equipment. In general, the things that they have here at the hospital are better, but there are some circumstances where your home equipment is just as good or you're just more familiar with it. So it's always a conversation with them. If there's a reason that you can't bring it, they'll let you know. It's usually something related to patient safety.
Understood. How do you get one provider to take charge of your care during a long admission? Teams always change, resulting in fractured care.
Oh, I know it. I am so sorry because that is so true. The problem, the hospitals I've worked at, usually the physicians will work like a week on, a week off. Like everybody needs a break, right? So there's a specific doctor who's in charge of your care for a week at a time, but then they, take their week off and you have a new doctor who's taking over your care. And it can be really frustrating because you have to re-explain all over again the different circumstance that's going on. Every hospital is going to be different on if you can have one physician take charge of your care in that way. I think that was more common in the past, but isn't as common now with the current system. Is a conversation you can have with the doctor to see. I have had doctors who like haven't had any other patients on the, usually they group like patients together, like a specific doctor is seeing 15 patients all like their rooms are all in a row, but I've had one doctor who just sort of had like a special relationship with the patient and like kept that one, or like when they came back onto work, took that one. So you can talk to them about it. There isn't a specific policy against it that I'm aware of, but it is challenging.
Well, thank you for your transparency on that difficult topic. Um, I do have two questions regarding accommodation, so I'm going to combine them a little bit. One person had a question. Whenever they go, they're not able to reach the control button for the bed. And then another person wanted to know about accommodations for toileting. So anything in that range from, how do you ask for accommodations in a hospital, and, how much are you likely to receive?
Well, it's so hard because it is an institutionalized setting, right? So they have all their systems set up, and they're definitely not set up for somebody who has a neuromuscular disease, and it's not going to be like it is. For you should absolutely be able to reach your call bell. So I do think that communicating that need to the nursing staff is crucial. I also wonder if they could have somebody like the occupational therapist come to the room to assess to see if there's any modifications that they can make. Like the nurses might not know off the top of their head a way to immediately fix or resolve that concern, but I'm sure that there's ways to alleviate it, because it is really important for you to be able to call for help when you need it. And as far as toiling goes, I would also lean on the OT specifically, to see, the hospital should be fully souped up with like the Hoyer lift and the bars and everything. But I do agree it will be different than it is at home and definitely not as comfortable.
Great points. Thank you. What advice or resources are available for patients who don't have a support system?
It's very challenging when you don't have a support system. I think a great resource can be, if you're eligible for any programs. It's dependent on the state that you live in and the county that you live in, but there are programs available that provide case management support for individuals, that could be really helpful to at least have a have somebody that you could call if you don't have any close family or friends that are available. Um, I think that's the best avenue for reaching out for that kind of support. Like we talked about like group home staff before. Not everybody wants to live in a group home, and that doesn't always make sense for a lot of people. But there are different programs set up similarly that could give you some of that plugged in support.
Great. And then just to add to that question, out of personal curiosity, you had mentioned like a chaplain or spiritual advisor on staff. Would they know about not only maybe religious groups to get involved in, but also just general community groups to get involved in? Would that be a good resource for that?
I think so, that or a social worker too. It depends on what kind of group you're looking for, but most chaplains now are pretty interdenominational in the hospital setting. So even if church isn't necessarily the thing that you want to participate in, or whatever religious group of your preference, they would likely be able to also connect you with other groups that can be really supportive.
Great. What to do when the hospital denies taking prescription medication from the regular MDA doctors? I'm assuming that means you come in with your medication or are prescribed while you're there.
It can be really difficult. I would see that a lot actually with patients who are on like it does happen basically in the hospital setting where there is a specific medication that is not available from the hospital. It's like too specialty, and the family has to bring that in independently, and the nurse can administer it. So it is possible. I would say that if the hospital is declining to do that for you, I would definitely want to know the reasons why, if there is a safety reason, or if they feel that they have the same drug available, but you feel that it's different. I think reaching out to a patient advocate to help be that bridge for you to make sure that everybody's understanding and you're feeling heard, that this is something that's important to you. Because they do have specific rules for like what medication they can give to you in the hospital, but it is possible for them to give you your home medication, especially if they don't have an equivalent to that they can give you from their like own hospital pharmacy.
Makes sense. Thank you. And then I just have one final question. While I'm asking this, if anyone else has anything they'd like to ask, feel free to add that into the chat box. But you mentioned visiting and caregivers and that type of thing. If you're a caregiver, how can you find out what is allowed in the unit? So flowers, food, etc. Do you just call a main line? Do you ask for the unit?
The best thing that I can think of is to call the unit, which can be easier said than done because sometimes they don't always pick up the phone. The nurses are busy. You can always just call like the main operator too, and ask them, is there anything that's prohibited? Um, anything you're probably going to bring though is pretty common sense, and is probably okay. The biggest thing I can think of is if the person that you're visiting isn't able to have certain food textures, like bringing food might be challenging. So that might be something you maybe the first visit don't bring the snacks. Maybe the first visit just bring the flowers or a card or something like that. But if you're able to come a second time, or if you're not, maybe just send in some food if that's okay for them to have.
Understood. Thank you. Well, I think that's all we have for questions. So thank you so much again, Julianne, for being here and for sharing your knowledge with us.
Thank you guys so much. I really am so excited to be here. So thank you. Appreciate the opportunity.
Yeah. Thank you. Now, for everyone else, I'm just going to wrap up here and give you some more information about MDA's programming. This year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum toward transformative progress for people living with neuromuscular disorders. To learn more, you can visit the link in the chat at mda75.org. Again, I would like to give a special thanks to our webinar supporter, Amgen. And last but not least, we invite you to join the MDA community. Joining is free and will help you stay up to date on our programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. We again would like to thank Joel Kartner and Julianne Meiser for sharing their time and expertise with us today. We want to hear from you as well. What did you like about today's program, or what can we do differently in the future? Please fill out the brief survey that will pop up right after this webinar. Your feedback is very important to us. If you have any questions or are looking for any additional support or resources, please contact the MDA Resource Center by phone or email. The contact information is on your screen and should also be in the chat box. You will reach a live person and they will help connect you with anything that you need.